Some observations that I see just scouring the industry. Vaginal childbirth has been destroying vaginas since the beginning of time. This is not new. However, the attention that certain aspects of the trauma that results from this is something that certain elements seem to be as if childbirth was invented yesterday. Vaginal laxity is something that academia has chosen more or less to ignore. Certainly on the other extreme, we have all kinds of therapies, treatments, and academic interest in vaginismus. If it's too tight, academia is okay with it. If it's too loose, it's not a problem. Academics have decided that vaginal laxity is not a medical problem, that it is not a condition that warrants the attention of the traditional societies. But since the beginning of time, everybody knows that childbirth produces laxity. Women know all around the world that there are groups of cosmetic gynecologists who are bringing attention to this topic. The industry has found that there are machines that can assist in the treatment, in the management of vaginal laxity. And what we have here now is the information age. There's no longer a wall where academia holds back all of the knowledge and all of the research and allows it, permits it to be filtered down to patients. This is a new world. The information is out there for everybody to assess. So the information that I have is the same information that a patient has. An innovation in Poland is an innovation that's known about by patients all around the world, in Greece, in London, in the United States. The information is out there. What the patients don't have are the filters to assess the quality of the information. But the women that want relief are no longer being held back because of the academic wall of knowledge. That wall no longer exists. They know there's relief. And they will gravitate to whoever is listening to them. I want you to later Google vaginal laxity and see what shows up first. Who's paying attention to these women? It was shocking to me. The first time that I Googled this, the first hits were the plastic surgery societies. And people just trying to sell machine-based products with large advertising budgets. Now, very few plastic surgeons are trained in gynecology. In fact, I can't think of any that I know personally. The cosmetic end, yes, there are certainly people doing this kind of work, but when you get into the laxity, nobody has a background in gynecology. This is what shows up when you Google vaginal laxity. The first society that says anything about it is the American Society of Plastic Surgeons. They use the words vaginal rejuvenation, vaginal laxity. They address the sexual side of these things. And they're an official society, a real organization of professionals, known academics since the 1930s and the 1940s. Every bit as influential as the American College of OB-GYN, the Royal College of OB-GYN, and all of the major OB-GYN colleges throughout the world. But none of those societies believe that we should be using the word vaginal rejuvenation. That style of thinking might have held sway in the 1960s when there was a wall of academic knowledge and it was filtered down to patients. But that wall doesn't exist anymore. You can't fight a 2020 battle using 1960s technology. It doesn't work. So what has happened now is they have chosen to ignore the number one issue, the number one consequence of childbirth, which is vaginal laxity and everything that goes along with it. Oh, it's okay to talk about the pelvic floor if you have incontinence, if you have prolapse, but we can't mention laxity, and we can't call that vaginal rejuvenation. They've been trying to demonize the early adopters, to demonize the people doing the research. Of all of the people providing these services, the ones we should be the most concerned about are the ones that know the least about the pelvic floor. Sure, the machines make these treatments easy to do. They make them easy to recover from. They make them very low risk. But that doesn't mean that a treatment is necessarily going to work. It doesn't mean that a treatment is necessarily being done at the right time in a sequence. It doesn't mean that financially to the patient, it's the right move at the right time. And this you would know if you had a background in pelvic floor, in gynecology, in urogynecology, in urology. But the industry likes to sell machines. They'll sell it to anybody with the money. Now, there's a lot of traditional gynecologists who are starting to become interested in these procedures. You may be one of these people in the audience right now, but you may have never been in a situation where you're discussing money for procedures with patients, because right now, if you're in a traditional practice, the money is being managed by a third party. You submit your paperwork, you beg for your money, and eventually you might get a little bit of the money. And now you have a machine, you have a treatment, you have treatments in which you're bringing in a patient and you're dealing with the patient directly. If you have no experience in this situation, you're going to make mistakes. So that's another issue that I want to address. We're in an age right now in the industry, in the specialty, of proliferation of many things. And we have to address the things that come along with this proliferation. It's a problem, but it's also a solution. If we have a lot of technology coming out, we have a lot of confusion that's arising as a result of the technology, because there's overlapping indications, there's overlapping results, there are overlapping regimens. Some like to combine different techniques and technologies, and everybody seems to be funded by a lot of industry money. So you have a lot of very convincing pros coming out there. And we have a lot of ideas coming out. Dr. Bader just showed you a slide with all of the different societies that have been involved in cosmetic gynae. 20 years ago, there were none. So what does that mean? That means there's lots of thinking, a lot of minds, a lot of educated people trying different things on different patients. And this is a great time to be in this specialty, because so many new things are being tried. But then we also have the proliferation of a whole bunch of nonsense, of people trying to take advantage of this for their own personal gain, ignoring some of the positive and just trying to exploit. Some of the trouble that I see is a confusion, a blurring of results and reviews. Reviews are great for marketing. Reviews are how many people rate experiences. But an experience sometimes is more pomp than actual results. Okay, they may be rating that they like the doctor's office, they serve good coffee, and they do a so-so procedure. That gets 5 stars. Whereas if the coffee is bad and the temperature was a little cold and the treatment was excellent, that's 3 stars. So that's the kind of thing that just doesn't show clinical data very well, but the industry uses it all day long to market their products. There's nothing wrong with marketing. We need to focus on the science. We need to focus on the clinical data, because that is the language of results. Now, the academics have kept bashing all of the cosmetic gynecological work, saying there are no results. There's no data. There's no real research beyond, I have a 12-week study, I have a 3-month result, and then there's no follow-up. It's difficult sometimes in the aesthetic space to do clinical studies and do the sham, do the control group, because the patients are paying money for results. They're not interested in being part of a study. It's a difficult population to assess clinically. But then when they bash, they also exploit, and they also use and make claims without data. The famous 2007 position statement against vaginal rejuvenation only had one reference. That one reference was an anatomic study of 50 British women. And the conclusion of examining 50 British women in stirrups was that labia come in different shapes and sizes. Now, how do you take that paper and use it to make a statement that says that pain and scarring are the result of labiaplasty procedure? I mean, you can say that. Give me a reference. Don't give me a study of 50 women in stirrups have different size labia. Therefore. So they also make dataless claims. And right now, the American College of OB/GYN is having their annual meeting and patting themselves on their back how up to date they are on cosmetic gynecology. Last year, they held an expert panel, pro and con, on cosmetic gynecology procedures. The pro has never done a labiaplasty. The con had maybe done 2 labiaplasties. And labiaplasty is about as deep as they went. They didn't get into vaginal tightening, the vaginoplasties, or any of that. So now you have these 2 experts putting out an expert opinion at the academic meeting, and they determine what the worth of cosmetic gynecology is or is not. I have never seen a doctor that makes statements on behalf of the academic societies attend any of the cosmetic gynecology meetings of any of the major cosmetic gynecology societies since they started societies in cosmetic gynae. Don't you think if you're going to make an expert statement, you should become an expert before you make your statement? Aesthetic training is something that's necessary for all of these procedures. You can buy a machine and jump right in, but you're not going to do very well. You can start treating incontinence as a dermatologist. I saw one doctor on Real Self, otolaryngologist, who bought a machine. I'm not going to say what machine, now treating incontinence. And he gets great results. His patients are very happy. That's his data. Of course, you know, I spend my time when I have time to rip these people online, and you should too, because you know better. Here is the root of the hatred of academics of the cosmetic gynecology space. Everybody here is an early adopter and an innovator, and everybody there is a majority follow the crowd kind of person. It's just the way that they're built. So you have your academic and you have your early adopter. What's the difference between these people? We go to the same medical schools. We go to the same residencies. We start out in private practice or in academic practice in roughly the same way, but then we either wind up at this meeting or we wind up at the other meeting. What is it that differentiates these people, gives us the bad reputation, and gives them the aura? Well, it's all about risk tolerance. Some people just have a higher tolerance for risk than others, and there's nothing wrong with that. The early adopter is not afraid to see an opportunity and take a risk. Later on, the next group of early adopters are people that are desperate. Okay, the practice isn't turning out the way that they were promised when they started practicing, so that they're rushing, they're in a haste to add something to their practice, to supplement their income. You know how the saying goes. Now, some early adopters will take something they learned and they do it over and over again. They produce a consistent product. Others will try to improve the product, and others will try to rape their clientele and just use it for gain. The academics want to see data. They're afraid to make moves. They don't like to make mistakes. They don't like to handle the patient who's unhappy with a mistake. So they cling to the data. That's what they want to see. They won't make a move until you show them enough data. Now, let's get into some of the issues that the early adopters get into. This is what I call the reverse evolution. The first generation of developers of new technologies are usually very intelligent people with a lot of confidence and a lot of clinical experience. The second and third generation are borrowing from that to the point they don't even remember or know how these things came to be. So there's less knowledge in the second and third generation of early adopter that needs to be put in there with better education. And this leads to, in the beginning, you make ridiculous claims, the results aren't so good, you know nothing about the market, so you start pushing what you have, but you push too hard. And you start to say that it's going to fix everything. You think it's going to fix everything, that makes you even more dangerous because people will believe you. And then you also have the problem, I have 10 different things, I'm going to throw them all at the patient. And it's not good or bad, it's just a very wasteful way to practice. Some people want to use their one machine for everything. And again, it'll have bad results sometimes, good results other times, but it's the bad results that people are going to focus on when they want to criticize the entire field. We want to see adoption of cosmetic gynecology all over the world, but we want to see it done in a way that produces good results. It's used in an appropriate fashion and doesn't leave the patient with a bad taste in their mouth if something doesn't work out. So this data that we generate, if we generate it in the right way, will convince the ones at the academic meetings that maybe these technologies, techniques, this field has value, which we know, but it's necessary to grow this. We don't want to be fighting with the academics all day long. We want to convince them that what we have and what we do has merit. So it's up to us to set the standards. It's up to us to look for the abuse and to call it out whenever we see it. Like they say, if you see something, say something. You're the expert. Take care of your specialty, and we'll still be here next year and the year after that and the year after that. Thank you very much.